radioulnar joint and TFCC. Published by WordPress.com. Anatomy of DRUJ and TFCC. DRUJ, distal radioulnar joint, a synovial pivot joint between the ulnar head and the sigmoid notch of the distal radius. TFCC, triangular fibrocartilage complex, a thick, triangular fibrocartilage disc composed of several components. Central disc. Proximal concave surface. Articulates with the ulnar head. Distal convex surface. Articulates with the lunate and triquetrum. The central part is avascular, while the periphery is vascular. Volar, anterior. Ligaments, from ulna. Volar ulnoradial ligament. Ulnotriquetral ligament. Ulnolunate ligament. Medial ligaments. Ulnar collateral ligament. Meniscus homologue. Dorsal, posterior, ligaments. Dorsal ulnoradial ligament. AQ, extensor carpi ulnaris, sheath. Functions of TFCC. Stabilization of DRUJ. Stabilization of the ulnocarpal articulation. Force transmission. Suspension of the ulnar side of the carpus. Causes of DRUJ and TFCC disorders. Acute DRUJ instability. Isolated injury is rare. Often occurs with other injuries. Hyperpronation injury. Common in dorsal injuries such as Galeazzi fracture dislocation, injury to dorsal capsule and volar ligament. Hypersupination injury. Common in volar injuries such as distal radius fractures and ulnar styloid dislocations, injury to volar capsule. Essex-Lopresti injury. Involves injury to the dorsal ligament. Ulna remains stable while the radius moves relative to it. And TFCC. Published by WordPress.com. Clinical presentation, C.P. Pain, severe with pressure, supination, or pronation. Swelling, severe, often localized to the wrist. Deformity, dorsal type, prominence of the dorsal ulnar side. Volar type, narrowing of the wrist, with or without a sigmoid depression. Piano key sign, may be positive, especially in cases of acute instability. Imaging. X-ray, AP view. Check for radial shortening, greater than 5 mm, and dislocation. Lateral view. Assess direction of dislocation. Ulnar styloid fractures may be seen. Findings. Volar dislocation. Increased overlap at the radioulnar joint. Dorsal dislocation. Increased radial shortening. Treatment. Management of associated fractures. Use a cast for 6 weeks depending on fracture type. Dorsal type. Apply a supination cast. Volar type. Apply a pronation cast. If unstable, pinning with K-wires, from ulna to radius for stabilization. Management of associated TFCC injuries. Treatment includes conservative or surgical options, depending on injury severity. Complications. Chronic DRUJ instability. Caused by unaddressed acute injuries or malunited fractures, e.g., ulnar styloid fractures. Neglected TFCC injuries and inflammatory conditions like rheumatoid arthritis, can lead to instability. Iatrogenic causes, e.g., following Daric procedure. Clinical presentation of chronic instability. Pain, mild. Swelling, mild. Deformity, same as acute instability, e.g., ulnar prominence. Piano key sign, usually negative. Treatment of chronic DRUJ instability. For malunited fractures, osteotomy or ulnar styloid fixation may be required. Surgical reconstruction. Adams and Berger anatomical reconstruction involves using the palmaris longus tendon to reconstruct the DRUJ through tunnels in the distal radius and ulna. Daric procedure. Resection of the distal ulna, with reattachment of soft tissues to the wrist capsule. Sauve-Coppendigi procedure. Distal radioulnar fusion combined with proximal ulnar pseudoarthrosis. Limited ulnar head resection may be performed in specific cases.